The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell from Leading Age Michigan, and I want to welcome you all again to our Safe and Calm webinar for July 15. The past week has been a really eventful one, and while we were hoping for some forward progress in terms of being able to serve our seniors, we find ourselves continuing in the middle of an ongoing pandemic. And that pandemic continues to impact our residents and our organizations. Several executive orders have been issued that have removed some of our flexibilities, and other directives have been updated in the last week to provide more detail about some of the requirements. And I think the hard thing is that even when a new resource is provided, it takes a lot of time and energy for everyone to adopt and implement it. So today, we want to start with our regular agenda, but we've tweaked it a bit this week because we want to initiate discussions specifically about where to point our advocacy. As we go through the general updates, we will focus on some areas that have been revised in the last week, but also those that we've had ongoing issues with, and those for which we get a lot of questions. So we're going to throw out some ideas during the webinar about how the continuing problems continue to impact us and how perhaps some of the new orders will impact members. We have noted increasing community transmission across the state, and because of that, we believe that the governor has chosen to continue a lot of the restrictions. But at the same time, it seems that we're losing those flexibilities that we had been provided to help members get through some of those challenges. So we're going to dedicate our Friday webinar as a member forum for an active discussion about which issues most need to be addressed with the governor and the state. All along, we have worked toward a flexible and iterative advocacy plan, something that needs to be refocused and updated and changed on an ongoing basis, along with all of the new directives that come along. But we believe that we have to continue to push for resources and assistance that will safeguard our seniors and staff, and while working towards some quality of life both for our seniors and staff. And so we're going to point out some of areas of concern that we've identified, and we would like you to think about them and then perhaps be prepared to discuss them in detail on Friday. We're probably going to look at a different kind of electronic format that kind of promotes more discussion for Friday. So at this point, we're going to move to our standard agenda, and I will turn the presentation over to Dalton Herbal for our advocacy update.
Good morning, everyone. And as always, you can find the PowerPoint or PDF version of these slides on your GoToWebinar tool under the handout section. Today we have some exciting updates for people. We have some updates on Senate Bill 956, which is Senator Lucido's bill that would remove COVID-positive individuals from nursing homes or from being admitted to a nursing home. We have updates on the process regarding Public Act 123, which is those direct care worker $2 an hour increase payments. And then we have a update on a CON bill package that is moving through the House right now. So first, we're going to start with some updates on Public Act 123. We have heard that guidance will be issued as soon as today. And originally, the discussions with the department told us that they'll be issuing the guidance today, but we noticed that the meeting that they were planning to reveal that at was canceled. And as we all know, the state has limited resources right now as staff are furloughed and they're facing they don't have enough horses. And just a recap before we discuss the actual updates, our conversations with the department centered around considering the additional $2 per hour as a direct pass-through and not subject to the VCL limits. And we also talked to the department around establishing appropriate criteria for the PPE grant applications, specifically providing access to the grants for the full continuum and aligning the terminology used in those applications and in the bill with the terminology that's used in the governor's executive orders, specifically the language around what is a residential care facility, because that could mean a whole variety of things when you don't put a formal definition to it. So moving forward, the updates, we are proud to announce that the funds will be considered a direct pass-through. And as far as those PPE grant applications, MDHHS is still working on the application process and what the criteria will be for those applications. For the direct care worker payments, a reimbursement form and guidance letter will be sent out as soon as today, depending on when the department is ready. They said today though. And these reimbursement payments will be made on a monthly basis. These forms will be due on the 15th of each month. So as an example, you'll need to submit your reimbursement form via email on the bottom of this slide, that email right there, to the department by August 15th to receive your reimbursement payments for the month of July. And also SNIS will need to track eligible expenses and retain documentation of the payments once you've received them. And then once again, the email's on the bottom of that slide. There's also, shifting gears a little bit, there's currently a CON build package that is up in House Health Policy. They just took testimony on it this morning. This package includes bills to remove psych beds and air ambulance services from the CON process, increase the amount of representatives on the state CON commission, and remove covered capital expenditures from the CON package process. And we are currently taking a neutral stance on the bill. It's still kind of having everything worked out right now. And as seen by this morning's testimony, there's a lot in the air right now on this package. It's pretty large and people are working their way through it. Update on Senate Bill 956, which is the bill that would not allow a nursing home to retain or admit COVID positive individuals. And also the department would be tasked with creating quote unquote COVID hubs, one in each HSA for people to be sent to from the hospital instead of going to a nursing home. The bill was taken up by House Health Policy this morning. They received testimony. We submitted a letter asking them to consider all the data that is out there before they move on any kind of a solution for COVID in the state, as we know that the state has, or the governor has established her nursing home COVID task force to look at this, and CHART out of U of M has been tapped to do a study of the regional hub program and the regional hubs, and their data will be out shortly. And the nursing home task force is set to provide comments to the legislature by the end of August. And so we currently are neutral on the bill, as the bill is still very political, but we're hopeful that these conversations will bear something fruitful and positive for COVID care in our state and for Michigan's senior population. This slide is just a quick update on what that bill does and what that bill says. You may have seen this slide in past presentations, so I'm not going to go through it, but this is just for anyone who's curious. They have all the information right here on what that bill does, so we can move to the next slide. Lastly, MDHHS sought input from Leading Age and others throughout the state regarding a end of year adjustment to the QAS calculations. And there's two primary reasons for this. The first being the 6% increase in the FMAP, or the federal match rate, and also the fact that Michigan is experiencing a reduction in the SNF caseload, or patient days. Because of all this, MDHHS is projecting that members will see a positive adjustment in their QAS payments this fall. And just a quick note that members who fall within the 40 beds or less category will not see any difference. And this is because that payment calculation is written into a bill, so it would need a legislative adjustment for them to do anything with that rate right there. All right, I believe it's questions time.
All right, and before we get to those questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos up on the screen right now. These are the organizations that continue to support the association, but your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. Right now, I just have one question, and that is, when the guidance is published for the $2 direct care worker wage enhancement, will you send it out on the SNF listserv?
Absolutely.
All right, well, it looks like that is the only question, so it looks like we can move forward.
Okay. Well, thank you, Dalton and Blake. This takes us to our standard weekly but very brief discussion of our national and U.S. situation in terms of the pandemic. These next few slides are based on data out of Johns Hopkins, and this first graph looks at the U.S. picture compared to other high caseload countries. It's an ongoing look at daily cases per million population. So you can see at this point that the U.S. continues to lead in daily caseload per million. However, we fare a little bit better when we're looking at the daily deaths per million population. And while the proportion does continue to increase, it is at a much slower and steadier incline compared to the number of cases. So that's at least some good news. This next slide identifies the number of active cases per million. And you can see that the U.S. has very high numbers in comparison to some of the other really high transmission countries. Our last slide in this series is also about active cases, but this is just the total number. It is not adjusted per population. And if you think about this slide in comparison to the others, this is very disconcerting when you're looking at how many cases we have compared to other countries at this point. This next slide is a slide that I've often used, updated portions of it, and it comes from the Financial Times. So this slide always tells us the U.S. proportion of new deaths using a 7-day rolling average. And we have effectively decreased it over time. If you note on the far side of the slide, though, you can see how it is now increasing again. And at one point, the U.S. accounted for 1/3 of the deaths in the world on a daily basis. And that decreased considerably, but now we're rising again and can account for up to 14% of those daily deaths. Here in Michigan, we've had some alarming increases in caseload over the past 2 weeks. And for this week's webinar, I've included 2 versions of the caseload slide. Lately, because of the length of the pandemic, I have been looking at a 7-day rolling average of daily caseload over just the last 60 days. So I'm always lopping off the data that happened earlier in the year. And that's the graphic on the left. That's the slide that I've been showing most of the time. If you look at the slide on the left, this is the caseload since April 1. And it shows you pretty much the number of daily cases as of yesterday compared to the 1st of April. And you can see that while we are inclining, we're not at the levels that we were in March and early April. Although the left side the left graph kind of indicates that we're heading toward those levels a little bit more closely. So I wanted to show both slides so that you can see that while we are increasing and it is meaningful, that it's not quite at the same levels as in the beginning. In terms of a 7-day average for daily Michigan deaths, we continue to see that there is a remarkable decrease over time, but as caseload goes up, there's likely to be an increase in the number of deaths, and that data will lag. So we could be seeing the beginning of some increasing death rates here, or it could be just a blip, because we know that a lot of the new caseload is younger persons. So we'll continue to watch this over time. This next graph is from the MDHHS website on Monday. It is important to note that the numbers published by the state on the front page don't include the probable numbers. So you can see that adding the probable cases increases our numbers to more than 77,000, and this was as of Monday, so I know it's higher now. When publishing the state data on national websites, they will use the 77,000 number. This slide also shows one of our main concerns, that the regions that are used to determine levels of community transmission have a large number of counties that have varying amounts of current cases, as you can see on the map on the left. While there are some regional trends, in other words, if you look at Southeast Michigan and West Michigan, you'll see higher numbers there, but they don't necessarily align for every county in the state. So if we move to the next slide, you lose that variability when you look at the MySafe Start map, which changed significantly last Wednesday, but it still looks like this as of yesterday. So it's that lack of variability in applying those testing requirements across large regions that we still have major concerns about. Last week, the overall percentage of tests that came back positive was 2.9% across the state. As of yesterday, it was 3.3%, which is a significant jump. And of course, that jump pushed weekly testing of staff to every nursing home in the state. So that county issue is one that we think it's important to continue to push on. So that ends our numbers update, and we'll now move on to our provider resources and update section. This morning, there are several areas we're going to focus on. We're going to look at the executive orders, a continued review of state guidance on testing, reporting, and visitation. A lot of that has been updated since Monday, and we get a lot of questions about those 3 areas still. And we're going to end with some nursing home only topics and a review by Laura Funch of recent infection control survey findings. So we'll start with some general updates. Leading Age has updated their resources on provider relief grants. While these guidelines have changed a bit over time and have become more detailed, this does not necessarily mean that there's recent changes in the guidance. It's just that Leading Age has updated their review of the rules in plain language, and those changes are reflective of the rules as of July 13th. And they always note that members should continue to look at the HHS FAQs as well. Additionally, we want to remind members that the due date for requests for Medicaid targeted provider relief grants is next Monday. Members should have already received the application information. This is not the first time we've talked about it, but we thought it was important to remind everyone because, money is involved. The link is here, and the actual letter, L2040, can be found under Policies, Memos, and Letters for your review. It also explains that these grants are for facilities who do not take Medicare and who have not received any Medicare provider grants to date. Last week, SEMA Verma released a video that explains the CMS plan for nursing homes. We did review this and didn't find anything really surprising there, but you might want to look at it. Additionally, CMS issued 2028 QSO 2028 revised, and it simply focuses on the rights of residents to access the ombudsman, but otherwise there was really nothing new in that directive either. So then we come to the executive orders. As of yesterday afternoon, we were up to number 151, which was an extension of the emergency declaration. So that was not a real surprise to anyone considering where we are in terms of transmission. Executive Order 147 was a mandate for masks in public closed areas. Also not a surprise. And although a bit late in being issued, we fully expected that 148 would be reissued and extended, and it was. It was a verbatim extension of the Regional Hub Directive. And lastly, we have Executive Order 150, and that's the one that concerns us quite a bit. It has taken away almost all the remaining flexibilities that we have had to address a lot of our staffing issues. So let's talk briefly about 148. There really is technically nothing new in 148. It has been a source of controversy, though, because it's about the regional hubs. We have learned that the Center for Healthcare Research and Transformation, we call them CHART, CHRT, will be doing a review of the regional hub project with a report coming out in the next month or two. They're going to be looking at the outcomes, effectiveness, performance of the hubs. And hopefully that information will inform the governor's task force who's looking at nursing home issues for the second stage of the pandemic. This director, if you remember, requires that all facilities, all types of facilities, attempt to create dedicated units. And that includes all residential care facilities except for independent living. And that if there are no dedicated units, nursing homes can transfer residents to regional hubs. There are some funding issues here with the regional hubs. Medicaid and Medicare fee-for-service will cover, Medicare fee-for-service will cover if you can identify skilled issues, but most Medicare Advantage managed plans, or at least many of them, will not. And that's an issue for COVID care overall, really. There has been some consideration to allow assisted living residents to move to these hubs, but the funding implications are even harder to deal with unless they become skilled. So at this point, many of these regional hub beds are actually being converted back since they're currently empty. So the regional hub mess has been problematic since the beginning, and we want to think about that critically as we try to make recommendations to the state as we move forward. So Executive Order 150 is the one that concerned us the most in the last week. It rescinded 61, which provided a lot of flexibilities, and now the only thing left from the original executive order are the CEU exemptions for licensure. We have listed all of the elements that have been rescinded here because it doesn't really say in the executive order which pieces are now gone. It only maintains the CEU issue for recredentialing and certifications. So we wanted to make sure that people understood which pieces are now lost, in addition to the few things that we lost in an earlier executive order with ancillary staff being able to help with some basic resident care issues. So this is a list, and one of the things that I noted that it rescinds is COVID tests ordered by nurses. So that is no longer allowed either. So we are we're going to be adding certain things of these as we've figured out which are the most important to our list to go back to the state in the next week. So we believe that the administration, for some reason, isn't understanding, for lack of a better word, I guess, the implications of some of the orders in terms of residential facility operations. And it feels as the pandemic is obviously continuing. We have a high number of restrictions, and yet we are losing our flexibilities that would help our members to deal with them. So that's what we want to talk about specifically on Friday. And to do that, we are going to be looking at some specific areas. So this next slide identifies some of the areas from the executive order that we're concerned with. We don't want you to specifically comment on any of these issues now, but consider them and be prepared to discuss during Friday's forum. Basically, we're still very concerned about the inclusion of unlicensed settings under some of the mandates and the limitations that places on such services as hair care, the inability to market for admissions in those settings and conduct physical plan updates that are not urgent, etc. We do know that there's a lot of different practices among our members out there, but technically these rules are making it difficult to do some of these things. Use of the regional hubs that are now decertifying beds, along with the access and payment issues there, those have been problematic, and you can tell from Lucido's bill that there's issues about those hubs. Also, there have been ongoing concerns about data, and especially with accuracy. And at this point, there's no transparency about what's really going on in assisted living level of care at all, although they are reporting as well. So we don't have a sense of caseload in anywhere except nursing homes. And as we will talk about later, the data with the nursing homes has kind of been questionable as well. So consider these along with the reduced flexibilities that we talked about earlier for our Friday discussion, along with any other issues that you might find important from the executive orders. Moving on to the MDHHS directives, we're going to focus on the big ones, of course, which are visitation, reporting, and for nursing homes only, the testing guidance. So starting with visitation, there are no real updates to the visitation guidance the last week. And this slide is a rather narrow summary of the requirements, and we're not going to go through these detail by detail. But because this impacts our residents and members so heavily, we want to review how we should focus our advocacy. A lot of the requirements for visitors make sense, but again, we want to review this next Friday, not only whether continued visitation restrictions make sense, but some practical ideas about what perhaps a safe visitation might look like and what the safeguards would be to apply to visitors, and which of those are best practice and make sense as well. So this next slide talks about some of our higher level issues, whether visitor restrictions are appropriate for more independent environments, the fact that there is nothing stopping movement out of a residential environment other than perhaps some discouragement during community transmission, high community transmission, but no one can come in. So this hinders construction, unit upgrades, and in some residential levels of care, admissions themselves. But mostly it forces significant isolation and decreased quality of life for our seniors and our staff, if you think about it. So we want you to consider these issues and the impact for Friday with ideas for best practices, and we will also talk about any other safeguards for visitation and what we think might make sense for Michigan. This is a reminder that a resident survey has been developed by Alterum that mostly speaks to the impact of isolation on seniors themselves. So it is a survey for the residents to complete. So we're encouraging nursing homes to have residents complete this survey because the data will be going to the state. And we believe that it might provide a better picture to the administration about the need to work harder towards safe visitation. The link is in last week's newsletter. We will send it out again. In terms of reporting, there have been some updates for nursing homes in the last week. These are just the new items that are listed in the FAQs. If members don't want MDHHS to submit their caseload data to the CDC, then members should make sure that they don't include the NHSN ID in the daily EM resource report. You must do Michigan reporting daily, but there's a way to update it every 24 hours if you haven't had any new data. There's a reminder here to place a 0 in any areas where there are no new cases. And also, one area of concern for like the last month or so is that nursing homes should report only facility-acquired cases. And each positive person should be included only once. They could be tested positive more than once, but they really only should count as one case. And also, if an asymptomatic person tests positive and then negative later, you should still consider that person positive and treat them as such, since false negatives are more likely than false positives. Again, for nursing home reporting, members should report deaths for persons who died in the hospital if they were transferred with COVID or were still considered a resident while in the hospital if they expired there with COVID. For persons who happen to move to the community and died from COVID, they're not to be counted. Do not include in the death count anyone who died after recovering from COVID as long as they meet the recovery criteria. And again, there's a way to update your data daily in EM resource, but not have to re-enter it item by item if it doesn't change. And the website will tell you how to do that. Now for the big one, there was a lot of changes for nursing home testing guidance. The department updated a lot of these documents on July 9 and July 10, and here are the links for each of them. Executive Order 148 continued the requirement for testing. We have included a lot of the testing detail here in the next several slides. Since there's been so many questions about it, but we'll only focus on the problem areas and the new guidance per se. One of the areas or issues that we've struggled with a bit is the protocol for staff who are asymptomatic and refuse testing. The guidance suggests that facilities can review a situation where a staff member refuses to be tested and determine that they could move them to a work assignment intended to avoid resident contact. That continues to make no sense to us since everyone who enters the facility has to be tested, and persons who are not in areas of resident contact have to be tested. So everyone else needs to be tested in those areas. Why would you move a staff person there? It almost is an incentive to have all non-resident care staff decline testing if that facility follows that policy. Now, that's a proposed policy. It's not required. You can have other policies as well, but it just doesn't make any sense. This is a continued review of the nursing home testing FAQs. Many providers have experienced significant barriers to getting their testing done, and they have notified the state. The state has let us know that members or providers do not need to notify them if you can't complete testing. What they want you to do is document the specific barriers to that testing within the updated template for your testing plan. And so one of the links that we provided earlier is an updated testing plan template that includes new fields for that information. But you don't have to report it to MDHHS if you can't get your testing done on time. One frequent question that we get is how to address persons who are not actively working or who work only intermittently. They can be excused for testing if they're not available, but they must be tested as soon as possible on return. And of course, the guidance has specific instructions about future testing of persons who test positive. And those are on the screen there at the lower portion, and we've gone through those before. The FAQs do state that the department may consider going to a county level to determine transmission risk that will impact weekly testing. And we hope to use that as another point to restart that conversation with them. Staffing options are available for the West and Southeast Michigan. We're not sure how that's really working yet since that's relatively new. In fact, none of this information on this slide is new in version 3 of the FAQs. Although the information about nurses being able to order testing is not current since it was removed in the executive order from earlier this week. This slide starts with all of the new information that is on the updated testing FAQ. Facilities requesting support need to use the request template and send it to the department, of course. There's not many surprises here in this new language, except the expectation, perhaps, that regions 1 through 5 and 7 must complete staff testing by 7/17. Regions 6 and 8, who now have to do testing, they have until 7/27. Again, this is more new information included in the nursing home testing FAQ. Staff who refuse to be tested cannot have direct resident in contact, but facilities must determine their own policies to deal with this based on their collective bargaining agreements, etc. Facilities should continue weekly testing even if results are not back. And the state says in almost all of our calls with them that they continue to work on turnaround times. Any new facility acquired positive case will provoke both resident and staff weekly testing requirements until 14 days after the last onset. And if staff become positive but have not been actively working from 48 hours before and through the entire transmission period, you do not have to test all of your residents and staff just based on that. The state also updated the testing reimbursement guidelines. Basically, the state will continue to reimburse for test collection even if the state themselves provide the test kits. Labs should be billing Medicare, fee-for-service, Medicaid, and Medicare Advantage plans directly. So members should not be getting invoices for them. Facilities should submit testing reimbursement forms every 2 to 4 weeks, and those forms have been updated now, finally, to actually include the lab costs in addition to collection costs. So facilities will receive lab invoices for any uninsured or commercially insured persons, and they are supposed to pay laboratories up front and then submit the form to the state. Facilities are asked not to submit any invoices or personal health information, but have that available if necessary for audit later. The new testing reimbursement FAQs summarize the process here. We've listed this pretty much verbatim from the new FAQ. They suggest requests be submitted at least monthly or every 2 weeks is okay. And members should expect payment via electronic fund transfer in 5 days if there are no issues with the submission information. So what are the advocacy issues with testing and reporting? We have concerns, as we said, with some ideas for policies around staff who refuse testing. And yet we also understand that testing itself is burdensome and we could lose staff over this issue. The overall staff burden for just collecting and coordinating testing is huge. And we do think that a county-based risk model might be more appropriate. We do understand that there is risk to seniors and nursing homes in areas of high transmission, but the state is not, consistent in terms of that transmission really across different areas. Access to testing supplies is not universal. Turnaround time is improving, but not perfect. And overall coordination, it's just very burdensome. So for Friday's discussion, we want you to think about these areas and identify the impact of these and any other issues around testing reporting that you might want us to put in our advocacy plan and our discussion documents. This slide is just a reminder that there are other guidance out there from MDHHS. Nothing new, but these memos are still in effect, and the HFA AFC FAQ has not been updated since 6/17. And I would anticipate that perhaps it should be hopefully soon, because with the executive orders, a lot of those flexibilities have changed, although we want to talk to the state more about them in the near future. This slide is just a reminder that it's helpful to be registered with MyHand and the Michigan State Police, although the state does keep telling us that they will start issuing guidance based on LARA's licensed facility list. I'm not sure if they've actually done that yet. So those members who are unlicensed entities should especially make sure that they're registered with these two sites for updates if they have not done so already, because there is no good way to communicate some of the directives to them. So at this point, we're going to pause for some questions, and from this point on, we're going to be talking about nursing home only information. So Blake?
All right. Again, Leading Age Michigan would like to thank all of our business partners and vendors, and we are thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. So please take a look at this list of names here, and just like the sponsors, whenever you are considering a purchase of goods or services, please remember this page and consider making a purchase from one of these fine organizations. Now, I do have a few questions. What impact does the increased testing have on caseload?
It does have some impact on caseload, but it also, some of the caseload increase comes from just more transmission as well. So I don't have any numbers to support how much impact each of those pieces have, but knowing that the testing, the positive testing number percentage went up from 2.9 to 3.3% over the last week, is a sign that there is more transmission. The issue is not just that we're testing more.
Okay. Do we count COVID death if resident was transferred and admitted into a hub and then died at the hub?
I would think that you would if the COVID case occurred in your facility, but I have not seen any specific guidance about that, so that's a question that we will take to the state.
Okay. In regards to testing, I am hearing more about point of care COVID testing. The Abbott test is molecular and seems to be quick. Is there any guidance on this being an acceptable testing method, and is anyone in Michigan using this system?
We're going to talk about point of care testing toward the end of this webinar. There are point of care tests coming out to nursing homes in the near future. So I would like to hold that conversation until then. However, I want to go back to the last question. Yes, while I haven't seen any guidance for how regional hubs should measure their COVID cases, the COVID case is supposed to be counted that's facility acquired. So if you transfer someone to a regional hub, that's not going to be their facility acquired case. So yes, it is the originating nursing home that must count that case. So I just wanted to be clearer on that.
All right. Are surveyors being required to test weekly since they are entering facilities on a weekly basis, albeit not the same facility?
I don't have any information about that at this time. I would think that it would probably be a good practice to test the surveyors. However, if you look at the strict requirements, I would say that they don't fall into any of the required testing groups, but I would hope that the state would be testing their staff. And that's something that we can ask them, ask Laura about.
Okay. Now that hospitals are supposed to report COVID data directly to HHS and no longer supposed to report COVID data to the CDC, do you expect that LTC reporting will follow suit?
Well, I really can't anticipate what's in CMS's mind, but I would think not. I would think that this system, which is just been updated for long-term care, specifically nursing homes, will probably continue. But I have not heard anything that would make me think that they're going to do that. And so I would assume it's going to stay as it is. But again, I can't anticipate the feds.
Okay. I joined late and apologize if this has been discussed. Will an invitation be sent out for the July 17th, 11 a.m. call?
Yes. Everyone who is already registered for these webinars should get an ongoing invitation, but we can send out an additional invitation. And in fact, we would like as much leadership there as possible because we think that it's really important to make a pointed effort to increase the administration and state's understanding of the operational difficulties here. We have continued those conversations over time, but the issuance of this last executive order has concerned us quite a bit.
All right. And then also, is there a set schedule for these webinars? I know you send an email, but sometimes I have things scheduled and miss them. I can answer this one. Yes, there is a set schedule. It is every Wednesday at 10 a.m. Eastern Standard Time, and then it is every Friday, 11 a.m. Eastern Standard Time. If there is any type of change, we will usually notify you in the our daily COVID update that goes out. We would usually address it there and say that it would be canceled whatever day that may be. All right. Has there been any discussion about how interns will be classified by any other members? Assuming the no visitor rule will likely continue to be extended, is there any recommendation on how we should treat interns? Are they volunteers and thus not allowed entry, or can they be viewed more like an unpaid staff?
Well, my take on this would be is that they would be considered essential staff. I don't, while I guess it's whether or not you consider them essential staff or whether or not you consider them covered as someone that you can use to support your staff. I think the executive order speaks to whether or not you can use this person to support your staff. But I would think that interns would be an essential part of your overall worker force. I can't imagine not having interns for the entire length of this COVID pandemic. But again, the guidance doesn't really speak to it. And at this point, I really don't like to anticipate what the state or the feds think about anything. So we can submit that question to the state.
All right. If CNA hasn't passed their test yet, can they still work?
I believe yes, but let me check about that. The feds continue to have a blanket waiver for that. However, they do note that it is up to the state as to whether or not they can do that. And I'll be honest with you, off the top of my head, I can't remember if that was one of the pieces that was stopped or not. I will have to go back and look at it. I don't think that that piece was in the recent executive order from Monday, which I think was 150. I think that that's from a previous executive order, and I'll go back and review it.
All right. Can CNA, LPNs, and RNs do their rotations in SNFs? And then they also added on clarification, students for CNA, LPN, and RN.
That's very much like the intern discussion. I don't have a good answer for that. I would hate to not continue that practice. I fear that the state might consider them non-essential, but we can ask the state about that.
Okay. Do you have information about nursing students being allowed for clinical site presence?
Same
Yeah,
issue, same question.
Yeah. All right. Can't CNAs still work under the normal regulation of 4 months after completion of program outside of the COVID expectations that, or COVID exceptions that were first allowed?
Yes, that rule has not changed, even if the state, excuse me, has eliminated some of the other flexibilities about using them. That rule still is in place.
All right, it looks like that was the last question, so we can go ahead and move forward.
Okay, so now we're going to go on to nursing home only kind of information. The table here identifies the data presented on the MDHHS website, and you can see that the numbers go up and down a bit, but they are now beginning to ascend steadily. So perhaps they're more accurate now, although to be honest with you, I thought that before when they started to take a dip. So whenever the cumulative number goes down, my brain immediately goes, you know, that can't be accurate. But unfortunately, we don't know where the inaccuracies are. If we move to the next slide, I just took the caseload, resident confirmed cases numbers, and showed you how they have changed over time. And these dates are not all really, they're consecutive here, but the state does not report them every day. So it's kind of, this looks smoother than some of the data reporting is out there. And you can see that it kind of wanes a bit, goes down a bit, but I'm hoping that that it feels more accurate in the near future without all of these ups and downs. Here are a couple reminders of dates for nursing homes. We went over these last week. We're reposting them as a reminder. One of the things that we have added is that testing for regions 6 and 8 is now due on 7/27. The next QIO training is scheduled for tomorrow afternoon and is on how to implement an infection prevention program in nursing homes. So it might be a good review for a lot of our members. So this is a big topic in the last 24 hours. Yesterday during a press conference, the administration stated that all nursing homes will be receiving point of care tests starting next week, with a list of 2,000 homes who are considered to be at highest risk. There were some voiced concerns about the reliability of point of care testing, but overall, this seems to be a really positive move in order to, excuse me, make testing easier for everyone. Facilities with a CLIA certificate of waiver. You're going to have a CLIA certificate of waiver in order to get these tests from the feds. Facilities who have that will be provided either one of 2 specific analyzer products. And those products use nasal swabs, so it's not nasal pharyngeal, and they will provide results in, I think, an average of about 15 minutes. So nursing homes can follow the CMS guidance to get a CLIA waiver. We have the link there on the left, and for more information, there's a press release link as well on the right. So we're not sure how long it's going to take to issue all of these, but until you get a CLIA waiver, you're not going to get one. So, and I know a lot of facilities don't have that, so I would suggest you all start working on that ASAP. There's also been an update to the NHSN long-term care module. We covered it last week, but we wanted to remind everyone of this updated guidance as well, and some of the changes in terms of definitions. So that ends my updates for nursing homes and other residential areas. And it takes us to the part of the presentation where Laura Funch is going to provide a brief overview of the infection control survey issues. And so we will now turn the presentation over to her.
Deanna, and hello everyone. Next slide, Blake. So on March 4th, CMS issued a directive, which you all remember, that suspended the non-emergency inspections across the country. This allowed surveyors to turn their focus on the most serious health and safety threats like infectious disease and abuse. From that, CMS's directive to the Bureau of Community Health Services, our state agency, they were to conduct surveys related to complaints and facility reported incidents, FRIs, that the state triaged as immediate jeopardy, and as well as targeted infection control surveys focusing on the spread of COVID. Next slide. So here is a review of the COVID-focused surveys that were completed between the dates of March 30th and June 30th. And the review of these are what was posted on BCH's public portal, which is known as SPOTS, which anybody can go in and take a look at, as of July 9th. These abbreviated surveys were a mixture of complaints and FRIs, and of course the targeted infection control surveys. So there were 474 surveys that were done. 28 of the providers, and again, this is the data that's in SPOTS, had more than one focus surveys. And the reason for this could have been due to a complaint filed after a focus survey was completed, or perhaps there was an increase of infection in the prevalence in the community, or from a decision from CMS's regional office. For instance, I do know that in a couple of the reviews I saw, CMS had hired an organization called Healthcare Management Solutions, and they came in to do a survey that had already been completed by the state agency. And they focused on the emergency preparedness requirements and the infection control. So overall, about 24% of the posted surveys resulted in an F80 citation. Historically, pre-COVID, the infection control rate, or excuse me, the infection control frequency citation has been #1 and sometimes #2 of the most frequently cited tag in Michigan, with an average rate about 16% of the surveys conducted. So there was an uptick. 59 of our 62 members have their surveys posted. Three members had two of the infection focus surveys, and 29% of our members resulted in an F80 citation. Next slide, please. This chart reflects the scope and severity of the citations. As you can see, the majority of the citations were at the second level. That's no more than minimal harm. However, there was a fair number of the citations at the fourth level, which is the immediate threat. And as you all know, that those citations result in heavier enforcement actions. Next slide. More than half of the immediate threat citations revealed some common deficient practices, which is listed here in order of frequency. Cleaning was a very high issue. Failing to clean the masks, failing to clean the rooms, failing to use the appropriate disinfectant, failing to clean shared services, not monitoring the temps of a dishwasher, PPE, not downing or doffing it appropriately, wearing the same gown in between cares, not using face masks, not using the N95 masks recommended to CDC, isolation issues, sharing rooms, COVID with non-COVID, leaving resident doors open for those who are in isolation, lack of dedicated equipment, hand hygiene. This has been a very frequent issue, folks not having hand hygel readily available or not washing them as long as they need to. They also cited CDC, the lack of the facility following recent CDC guidance. And some of the things that were in there talked about not assessing the resident every day, all residents every day, and being aware of the changes in their symptoms. And the other thing that continues to be big is about the active screening of healthcare personnel at the beginning of their shift for signs of fever, etc. So those are the common issues and the deficient practices that collectively a lot of the IJs had in common. So most of these deficient practices weren't really a surprise either now or pre-COVID, except for the updating policies that were consistent with CDC guidance. And I know that is a forever daunting challenge. Just as also a note, all these surveys that I'm reflecting here were due in part from filed complaints, either from a complaint or a FRI that was prioritized as an IJ. Next slide, please. I thought this was interesting. Some of the surveys had these associated tags with it, 684 and the emergency preparedness tag 24. They were also cited along with the 880. The quality of care tag was cited on a number of surveys. And again, so this is the trend that the facility hadn't ensured accurate, timely assessments. They weren't monitoring, they weren't notifying the physician in a timely manner when there was a change in condition, and unfortunately some of those scenarios ended up in the resident expiring. Emergency preparedness tag, a few of the facilities were cited for not implementing their procedure for contingent staffing when staff didn't show up, and so that was being cited. And again, that emergency preparedness tag, that was cited as a result of the Healthcare Management Solutions contract on behalf of CMS. Next slide, please. So now I want to talk a little bit about QSO 2031. This memo was issued June 1st. And CMS explains that it's because of the heightened threat of the resident health and safety, even in low isolated infection citations, things such as hand washing or PPE. CMS expanded the enforcement with the intention to improve accountability and sustain compliance. So as of June 1st, as of June 1st exit, any provider that was cited for non-compliance with F880, BCH will recommend a directed plan of correction as an enforcement remedy for CMS to impose. This is non-negotiable. This is a directive. So again, as our review of spots, it looked like there was about 20 providers who will be affected by this new enforcement remedy. The remedy will be effective 15 days from the date that you receive your enforcement letter, and the effective date is not the deadline for completion of the DPOC. So the imposition of the DPO does not also replace the requirement that you have to complete a POC for all cited deficiencies, including the 880 within the 10 days after you receive your 2567. So providers will have to submit a POC that includes the elements of the DPOC as well as any other actions that they have to take for the other deficiencies cited. Next slide, please. So in order to assist in identifying the appropriate corrective actions and implementing systemic changes, you'll have to contract with an infection control consultant who will provide consultation and oversight for the infection prevention and control within your facility. That consultant will be allowed to have independent judgment in the performance of the duties under the consultant contract. They will have completed an infection prevention and control training from a recognized source. This consultant has to have completed infection prevention and control from a recognized source. And they will have to be contracted to work with your facility for a minimum of 2 months. I think if you are affected by this DPOC, even if you're not, you may consider looking for availability of consultants already. I do know, my understanding is that APAC is a source that you could take a look at to consider consulting with or contracting with. The responsibility of the consultant is to work with the facility to conduct a root cause analysis to identify and address the reasons for the non-compliance. They should take immediate action to implement an infection prevention plan, which includes implementation of the appropriate infection prevention procedures, review all your relevant infection policies, procedures, and make revisions based on the results of your root cause analysis, and then work with the all facility staff that provide direct care, as well as any staff that enter resident rooms to provide dietary needs or to perform therapy, activities, cleaning, laundry, or maintenance to ensure they are fully trained on infection prevention and control, including all these topics that are listed here. And that is, that's all I have to say about that. Does anybody have any questions?
All right.
Hello?
Yes, give me 1 second. I am pulling those up. Can you repeat the source of obtaining a consultant? I could not catch the name you used.
I would suggest that you contact APAC, the Association Prevention, I think it's called Association of Infection Prevention and Control. Michigan has a chapter.
Okay. And then I believe that was the only question that I had for you, Laura. I did have another question that I believe was for you previously, Deanna. I said, what about AL for this point of care tests? I don't know if you need more clarification on that. You may.
Assisted living was not included in the CMS discussion. And in fact, I would think that that would have to be a state level resource because, you know, the feds don't cover assisted living levels of care. I do believe that assisted living facilities might be able to use point of care testing on their own, but the program that is coming out from the feds is specifically for nursing homes.
Okay. So I believe that is the last question that I had. So if you do have any further questions, feel free to shoot them off to either Safe and Calm, or you have Deanna Dalton's and Laura Funch's email all right there. So we would like to thank Dalton, Laura, and Deanna today for all of the information. We would also like to thank our members and participants. I believe we had right around 75 people today that took time out of their busy schedules to join us for today's webinar. We appreciate everything that you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Deanna, Dalton, or Laura, do any of you have anything else you'd like to say?
This is Deanna. I would like to remind everyone that we believe that Friday's webinar and/or it won't be a webinar per se, but discussion will be really important for us to make a pointed advocacy plan, and it will inform us how to focus our discussions with the state and the governor's office. So we ask that you all come back for that discussion. And Blake, please make sure that you send out a new link to everyone for those people who perhaps haven't been attending routinely, in case they want to be included. We are going to send out an initial list of issues so that you can think about them in addition to our discussion today. And we hope that you'll all engage with us and help us work through some of these issues.
All right. Thank you very much, Deanna. And just letting everyone know, if you are already on the webinar today, if we do go ahead with the web and just run it as a go-to webinar this Friday, you won't have to re-register or anything. You will be all set, and you'll just get the reminder as usual. So other than that, I think we are good. Everyone have a great rest of their day, and we will hopefully talk to you all on Friday.
Thanks.
Good day.